The LUNAR study was a single-center, randomized Phase II trial that we conducted at UCLA with my buddy and colleague Amar Kishan, radiation oncologist, main PI. I serve as the co-PI on the nuclear medicine side. We wanted to test the hypothesis of adding 2 cycles of lutetium PSMA therapy before SBRT in patients with oligometastatic, recurrent, hormone-sensitive prostate cancer. So we randomized patients into 2 groups, 45 patients per group. And in the control group, patient had standard of care SBRT. And in the intervention group, patient had lutetium PSMA, 2 cycles neoadjuvant plus SBRT. And then we followed up the patients in both groups with PSA every 3 months. And interestingly, with PSMA PET scan systematically at 12 months and at 24 months and at each PSA rise. The main findings, the PFS, which was the primary endpoint based on PSMA PET scan, was 17 months into the investigation group versus 7 months into the control group. So the hazard ratio was 0.37. Of note, all the progression events were mostly new lesions outside of the field. Another main finding of the study is the hormonal therapy-free survival. Hormonal therapy-free survival was initiated in case of new lesion on a PSMA PET scan or a PSA above 10 if there was no new lesion. And it was 24 months into the investigation group versus 16 months into the control group, so a hazard ratio of 0.40. So this is, I think, very relevant for patients who are trying to avoid ADT, and it delayed the initiation of ADT. In terms of toxicity, it was very well tolerated. It was a low dosing schedule, 6.8 gigabecquerel, 8 weeks time interval, so pretty much on the lower range in terms of dosing. And so there were a little bit of grade 1 bone marrow toxicity, dry eyes, dry mouth, and diarrhea, but low frequency, no more than 5%. So as a conclusion, in this Phase II randomized trial, we show that by PSMA PET-based progression-free survival, 2 cycles of lutetium PSMA therapy neoadjuvant to SBRT was improved in comparison to SBRT only. The toxicity was very well, the toxicity profile was very good. And I think the effect is mostly that lutetium PSMA is treating the microscopic disease that we don't see on the PSMA PET scan. The visible lesion on the PSMA PET scan, they were covered by radiation therapy. Still, we can do better. There were 60% of the patients in the investigation group who progressed ultimately. So maybe we can improve the dosing schedule. Maybe we can also use alpha emitters rather than beta emitters because they are more suitable for treating microscopic disease. Next phase, we will try to go to the Phase III, and so we're designing that now.